Very well. So we continue now with our second talk of the day.
Okay, so good morning. We are very glad to have here Dr. José Eduardo León Rojas. He is a graduated as doctor from the Universidad Internacional de Ecuador, specialist in advanced neuroimaging from the Queen Square Institute of Neurology at University College London, United Kingdom, categorized as one of the 10 best universities in the world in health science. At this center, he was researcher fellow in the departments of neurology, neurosurgery, and neuroimaging. Author of more than 30 impactful scientific articles and winner of the Dean List Award for Academic Achievement. He works as a researcher professor in the UCLA School of Medicine and is part of the brain, emotion and behavior CECU. He's a doctoral candidate in biomedical research methodology and public health and in education and innovation. Reviewing editor of the journals Frontiers in Neuroanatomy and Frontiers in Human Neuroscience, which is the foremost cited journal in the field of behavioral neuroscience. We are very glad to have Dr. José Eduardo here. And to the people who joined in Zoom, please write your questions down in the chat so the speaker can answer them in the corresponding section. And we also ask you to put your mobile devices on silent during the conference. So, Dr. José Eduardo, we are glad to hear you. So please go ahead.
Thank you. Hello, everyone. Good morning to everyone. Thank you for the introduction. A big thanks to a dear friend and past student, Emi, who made the connections for me to be able to talk here, as well as to the committee chair for the invitation. So today, let me tell you first a little story about a young woman that you can see depicted here. It's not her, of course, but she was a dental hygienist, and she always loved being a dental hygienist. She wanted to do that. Her mother was a dental hygienist, and her father was an orthodontist. She started studying to become a dental hygienist. She went through dental school. And then out of the blue, she started seizing. She started having convulsions, seizures, especially temporal seizures. One at first, they were being controlled by medication, but as the disease progressed, she started having more and more seizures, up to a point where she had 7 seizures in a day. She started taking anti-seizure medication, up to the point where she was taking 7 different pills every day. And despite having 7 different pills, she still had seizures, around 7 or 8 a week, sometimes when she was attending patients. So that was worrisome, and she was young. So what happens when seizure medication doesn't work? What happens when we cannot provide an accurate diagnosis for someone with psychiatric illness? What happens when we don't know if a crooked smile or a headache is a brain infarct? What happens if we diagnose Alzheimer's late? These are all pondering questions, important questions, and I really believe, and I hope that after the end of this talk, you will believe too, that advanced neuroimaging is actually the future and the answer to these questions. I will show you some of the answers in this talk, and we will talk about some future answers that may come. So this is why this talk is the present and the future of brain imaging. So once again, thank you to the Arkansas State University Campus Querétaro for the invitation. I'm very happy to share this information with you, and we'll be happy to answer any questions. So beginning with this, brain imaging is mainly focused now on MRI, magnetic resonance imaging. And magnetic resonance imaging basically uses the spin of the protons of hydrogen to create an image. And as you can see in this video I'm going to show you, this is an imaging of a coronal cut, meaning it goes from here to the back. And as you can see, the detail is basically mind-blowing, right? You can even see the brain as so detailed as a histological stain. This is a 7 Tesla MRI. Teslas come from the magnetic field. The higher the Tesla, the better the resolution, the more expensive the machine is. But as you can see on this video, you can see with deep detail the structures of the brain. You can even see the tiny bridges between the caudate nucleus and the putamen. I mean, brain MRI is getting cheaper. We're advancing the technology. In London, we have already 7 Tesla MRI. It's going to come to the rest of the world as well, which is going to make the 3 Tesla MRI cheaper. So what we're basically seeing here is that we can see with very good detail, with specific detail, tiny things that before we had to take a piece of the brain, stain it, and look it under the microscope. So this is advanced neuroimaging. This is the future of neuroimaging, and we're already doing it in humans other than animals. Now, imaging has evolved in basically incredible speeds, right? Since the beginning of MRI, in the few years, we have gone through multiple types of techniques, including nuclear imaging, which basically uses radioisotopes inside of the body to emit a signal to the machine. We have mixed MRI with other types of modalities, and we're going to talk about some of them in this talk. We have imaging that can basically measure volumes inside of the brain accurately. We have imaging to measure the movement of water inside of the myelin sheets of axons accurately. We have imaging that can measure the signal strength of oxygen inside of the blood. And we can measure basically the flow of oxygen per gram of brain tissue. We have imaging that can measure the electromagnetic fields that neurons create when they're firing a signal. So we have crazy things. It's basically like science fiction now. We have imaging that can focus on a specific area of the brain and basically measure its specter of signaling of the hydrogen molecules in the different types of components. And we can have spectroscopy, which basically tells you the amount of particles per million located in a tumor or in a specific unidentified mass of the brain. Before, and you should have known this, the ones of you that are focused in the fields of human science or neuroscience, we had this map here on the left and on the right, done by a famous pathologist named Broca, right? So we have the Broca's areas. This is something that they teach us frequently, right? A specific number of Broca area, and the books still use the specific number of Broca area is in this anatomical area and has X or Y function. But with advanced neuroimaging, especially with the Human Connectome Project, we have found Broca said we had like around 47, 48, 49 specific functional areas. The Human Connectome Project has found more than 200 individual functional areas of the brain, meaning that Broca is starting to move into the history of medicine rather than something we should use now, because we're finding out more and more often that brain function is specifically tailored to the patient. Meaning, for instance, Broca's area here, yes, I might have it here, but you might have it in the front and the upper or backwards, right? So the Brodmann area is here, and the Broca area, which will be number 44, it can be 44 like here for one of you. One of you might have it a bit higher up. One of you might have it a bit more anterior. Might you have a bit more posterior. So the Human Connectome Project is showing that there can be variance in these areas and that Brodmann areas are moving to be history. We need to do functional imaging on patients that we have to operate out of a tumor. Specifically, the tumor is in eloquent areas of the brain. And advanced neuroimaging is helping us do that, helping us map specific functions of the brain and try to create these tiny areas called parcels in order to do a proper segmentation of the brain and preserve function. Now, one of these interesting techniques of advanced neuroimaging is diffusion tensor imaging. Diffusion tensor imaging basically uses water molecules and the movement of water molecules in a space, okay? In this animation I did, you can see these water molecules moving randomly. When water is free to move, the molecules will take a random shape, right? They will move all the way around. They're free to move wherever they please. When they do that, if you measure the diffusion of the water moving freely, you will see that it will create a sphere, meaning that a water molecule has the same probability to move up than left and down than right and whatever, right? It's a sphere. You have the water is basically free. But what happens when the water is restricted? For instance, let's say we see water molecules moving like this. This is quite different, right? It seems organized, like they're in a line, okay? Like little ducklings following mama duck. So what happens then? So when this happens, you see a different shape of the diffusion. You can see like this, an ellipse, meaning that water molecules have more likelihood of moving along this axis than this other axis. And what is typical of this? Nerves and axons with the myelin sheath, because if we remember correctly, myelin is basically fat, right? And fat is hydrophobic, meaning that water molecules that are moving inside of the axon carrying the potential, because basically the action potential is carried in water, because the solids need to be in water. So the water that's moving through the axon is limited within the axon. So we can basically see the flow of water through an axon and the direction, if it's left to right, up, down, from front to the back. And we can measure those axons, measure the diffusion of those axons, and basically create maps that you have seen that look like this, that have even been used for covers of even CD albums, for instance, of Muse. So this is tractography, meaning it paints the tracks of the central nervous system, and it shows you important tracks that, if you have studied this, you might know: the cortical spinal tract, the fronto-occipital fasciculus, the superior longitudinal fasciculus, etc. You can map them. The more advanced the imaging software you have and the imaging hardware you have, the better you're going to distinguish these fibers. With 7 Tesla MRI and specific probabilistic algorithms in diffusion, you can see the difference between tracks beautifully from patient to patient and find it specifically in the patient you're going to operate or the patient you want to treat. So diffusion tensor imaging works for that. Here's a publication I made, if you're interested to look at it. It's published in the British Journal of Neurosurgery, and it looks into the function of diffusion tensor imaging in predicting the outcome after a pediatric epilepsy surgery. And this is important because in pediatric patients, you cannot operate them awake. It's very traumatic for a child to have an open brain surgery. So therefore, most of brain surgeries in children are asleep. But the issue with having a sleep surgery is that you can damage something without knowing, and you can only find out once the child is awakened. Therefore, using these types of techniques, the surgeon can map and know exactly where the functional tracks of that child are, and then try to avoid them during surgery. So there's function there, and there's an utility of diffusion tensor imaging in these regards. And diffusion tensor imaging is being used in multiple ways. We have kurtosis diffusion tensor imaging, which basically measures the probability of an abnormal distribution and non-parametric distribution of the fibers, which will be typical in the brain. And we're able to measure fibers and show them with more accuracy than before. Another technique that we use is spectroscopy. So what's spectroscopy by magnetic resonance imaging? And a specter, as for instance, the light specter, is basically waves, right? It's different, basically these things that some are high, some are low, some are taller than others, some are wider than others. That's a specter. When we measure the specter of hydrogen molecules inside of a specific part of the brain, a hydrogen molecule that is bound to another hydrogen proton that is bound to another specific type of molecule, for instance, forming choline, is different than the hydrogen that is joined to form creatine, and is different to the hydrogen that is formed or that is joined with N-acetyl aspartate. And therefore, those hydrogens are going to rotate differently because they're being influenced by the magnetic field of the other components of the molecule. So we can measure that and create a specter that shows us how much choline, how much creatine, how much N-acetyl aspartate, or how much myoinositol, how much glutamate a specific area of the brain has. And we can define patterns. For instance, in brain cancer, we know what is the pattern for a specific tumor, a malignant tumor. A malignant tumor typically has low N-acetyl aspartate, as you can see here. And we have been using spectroscopy to diagnose other types of illnesses. For instance, in this study, they compared healthy controls against patients with residual and not residual schizophrenia. And they found out that depending on the region, especially in the anterior singular cortex here in orange, in the insula and in the splenium of the corpus callosum, there's significant changes in these metabolites, and these metabolites can be used to differentiate someone with and without schizophrenia, and between someone with residual and non-residual schizophrenia. So we're moving away from the era where we used to diagnose psychiatric illnesses just with specific questions about the symptoms and the feelings of the patient. And we can move and show that mental illness is actually a biological and organic thing. And we can have biomarkers in neuroimaging that can be faithful enough and that can be easy enough to use in order to predict or to diagnose someone more accurately with a mental illness. So here you can see also another article we published with my research group, where we saw the functionality of brain spectroscopy in bipolar disorder and what areas in patients with bipolar disorder are being affected in spectroscopy and how can it be used as a biomarker. Additionally, here in this research that I told you, we found out, for instance, that N-acetyl aspartate, NAA, is decreased in the prefrontal cortex in most of the studies. It's also decreasing in the anterior cingulate cortex, but choline, on the other hand, is increased in the anterior cingulate cortex and is increased in the basal ganglia. Glutamate is increasing the prefrontal cortex, and myoinositol is increasing the frontal cortex. So these are results from multiple papers and good quality papers, but as you can see, we start seeing a pattern there. And maybe spectroscopy, once it overcomes some of its limitations, like for instance, standardization, can become a powerful tool to diagnose patients with other types of neurological illnesses that are often difficult to diagnose. Another study done by these students you have here, these 5 students, José Daniel Duque, Brian Miranda, Sebastián Martínez Ronnie, Juan Francisco Pazmiño, they're looking into the utility of brain spectroscopy in Huntington's disease. So we, again, find out some differences. There's decreased creatine in the thalamus. There's decreased creatine and N-acetyl aspartate in the caudate nucleus. And there's increased myoinositol and decreased N-acetyl aspartate, choline, and glutamate in the putamen. So you can see even in Huntington disease, and this is the difference between pre-manifest and manifest Huntington disease. The utility of brain imaging in the future will not only be to diagnose once the symptoms are there, but the utility of brain imaging will be to diagnose before the symptoms appear or when symptoms are mild enough. So we have even a predictive value of imaging in the future. Spectroscopy can even be used to predict if a tumor is going to be malignant by measuring this component, 2-hydroxyglutarate, because it has been shown that when 2-hydroxyglutarate is present, there's an IDH1 mutation in gliomas, which means that their treatment with chemotherapy needs to be different than the ones that are not mutated. Another type of spectroscopy is Raman spectroscopy that basically uses this tiny wand that you're seeing there, and you can do spectroscopy directly on top of brain tissue. And you are able to detect these type of specters or mutations in IDH without having to take a piece of the brain or do a biopsy and to look it under the microscope and do stains. So imaging gives us the benefit of being non-invasive and gives us the benefit of having a response without having to put the patient through a huge ordeal of having a biopsy or maybe damaging some area of his brain, having a condition all of his life. So it's better, right? Now, another type of technique is perfusion-based imaging. Perfusion-based imaging, what it does is basically measures the signal of oxygen in the blood, and you can measure the amount of both blood and oxygen that is reaching a specific part of the brain. And you can easily diagnose infarcts. For instance, here you can see that there's areas of the brain, in this case red hot, that are the areas that are receiving less oxygen than others. With this type of imaging, we can not only see infarcts, we can see neurons that are agonizing. So when someone has an infarct, it's basically like, I want you to imagine like there's a worm inside of your apple. Okay, you're eating an apple, there's a worm inside. If you start cutting the apple, you're going to see that where the worm lives, there's going to be like dead apple. There's not going to be enough apple. It's basically the home of the worm, right? That's the thing of the apple that is dead. But around of the worm, there's going to be a piece of apple that's still not dead, but that the worm is slowly eating and killing, right? And outside, it's normal looking apple. The same happens with an infarct in the brain. There's going to be a center that is completely dead. We're not going to be able to recover it. That's dead. If it passes more than 3 hours, it's completely dead. But there will be an area outside of that core, that is going to be dying. That's basically neurons that are agonizing, neurons that are drowning. If we don't do something to help those neurons, they're going to die. And how are we going to see those neurons screaming or dying? With perfusion imaging. With diffusion imaging, the one I showed you before with the tracts, we identify the death center, right? This is the yellow one. This place, this area here is dead. But with perfusion imaging, we can identify the area that is agonizing. In red, you can see the area that is agonizing. And here, on this imaging, you can see compared yellow to blue. Yellow is dead, blue is agonizing. So you see, with perfusion imaging, we see that this huge part of the brain here is dying still. And if it's agonizing, there's something we can do about it. We can save it. The issue here is when you only depend on this image, you say, okay, it's a tiny piece dead. You leave the patient be with, you hospitalize him, you give him some supportive measures, right? You're going to see that 24 hours later, this tiny piece that was yellow is going to be this whole blue piece. More of the brain will die. Why? Because there was still an area of the brain that was agonizing. So we can detect this, and we have changed the algorithms for treating a brain infarct, a stroke. Up to more than 24 hours after the stroke, you can still treat. When? When there's this mismatch. When there's a mismatch between what the DWI shows you, diffusion weighted imaging, versus what the perfusion weighted imaging shows you, the PWI. If PWI shows you that there's more brain to save, what do? You go in and try to save it. How? You insert a catheter through the arteries, you go into the blocked artery and you try to yank out the cloth. And it has shown marked improvements in patients, even in elder patients. So we have an imaging to literally see the neurons that are dying, screaming, and we can save them. Here you can see more examples of perfusion-weighted imaging, not only in stroke, but also in brain tumors. For instance, if we see this brain tumor here, right, you see a huge image, right? You see this white, you see, oh my God, this is terribly malignant. If you see the perfusion imaging, you see that this tumor doesn't get a lot of blood. In comparison, let's watch this other tumor, similar to this one in size, right? Then the characteristics of the imaging appear that this tumor is benign, but when we see the perfusion imaging, we see that it's getting a lot of blood, which is weird, right? Benign tumors usually don't get a lot of blood. So when perfusion imaging came about, we understood why some patients that were told they have low-grade gliomas, meaning less malignant cancer of the brain, we understood why these patients sometimes evolve into a malignant glioma and can die in a period of months. Why? Because apparently that tumor looked benign on imaging, but when you do perfusion-weighted imaging, you see that he's basically stealing a lot of blood, like a vampire. It means that that tumor, even though it looks benign, it's going to become malignant soon. Basically, perfusion-weighted imaging in tumors lets us identify the wolf in sheep clothing, meaning those tumors that look benign, but at the end are going to transform really, really fast in malignant tumors. Okay, so perfusion-weighted imaging has a prediction value there as well, and it's being studied even more. That we can see here in low-grade gliomas, you can identify specific areas of the tumor that have more blood flow than they should, and you should watch them closely because maybe they will turn into a malignant tumor. We can use also magnetic resonance imaging to paint the arteries inside of the brain. Usually, when you want to see the arteries inside of the brain, you can use two techniques, either CT, computed tomography. But the issue with CT is that it uses X-ray, right? You need to irradiate the patient, and you need to inject a contrast that is made with iodine inside of the patient to be able to see the arteries. You can also use magnetic resonance imaging, but you also have to inject a contrast that is gadolinium, right? Because it's a paramagnetic fluid and it basically paints the arteries and the veins. The issue with both techniques is that you have to inject something. And patients with, for instance, kidney failure are not going to tolerate that well. Patients can have an allergic reaction and a fairly severe allergic reaction that can kill them. So with resonance imaging, what we can do is basically send pulses into the neck of the patient, right? Where the carotid artery passes through. That pulse is going to invert the spin of one of the protons, meaning that the blood is going to start transporting protons of hydrogen that are inverted. And once the protons reach the brain, they're going to try to revert back to their normal state, which will emit a radiomagnetic pulse that we can gather through the resonance magnetic imaging machine and basically invert the colors that we're getting, and we can paint the arteries without the need of contrast. What we're basically doing is painting the blood by using its protons of hydrogen. And you bypass the need of injecting something into the patient, and patients with kidney failure, whatever failure you want, allergic to everything in this world, can still do this imaging and nothing bad will happen because we're basically not injecting anything. And by doing arterial spin labeling, that's the name of the technique, you can basically paint the arteries in such a specific way that it looks exactly like injecting contrast. You can detect aneurysms, you can detect malformations, you can detect changes in flow and everything just by using this type of technique without having to inject any type of contrast. As you can see here, you can even see when there's a stenosis or lack of flow. You can see on the other side, you see this artery here. On this side, you cannot see it. And this is using arterial spin labeling or time of flight imaging, both techniques that don't require the injection of any type of contrast agent. Now, what happens when we use all of the benefits of these techniques that I have told you, and we basically try to create a chimera, right? We try to put them all together and see what comes out. When we do that, we get a 3D multimodal imaging, okay? A three-dimensional multimodal imaging. What is multimodal imaging? Multimodal imaging is basically what the Human Connectome Project is doing, trying to map the specific functions of the brain by using advanced imaging algorithms. What we can basically do with multimodal imaging is we can measure volumes inside of the brain, localize the structures very specifically that we can pinpoint during surgery to the surgeon, meaning you're basically creating a GPS inside of the brain. With that volumetric information, we can put over the volumetric information, we can put information about the tracts using tractography that I told you at the beginning of the talk. We can put information about blood flow using perfusion-weighted imaging that I told you in the talk. We can put information of the spectroscopy to show the core of the tumor. We can put information about functional MRI, meaning to show where the function of a specific thing in the brain is. And all of that can be presented in real time through the neurosurgeon's microscope using augmented reality. So what you're basically doing is using all of the techniques I told you, packing them into a pretty bundle, and showing the neurosurgeon all of the things he needs to cut or to avoid. And that decreases the surgical footprint in the brain. So what we're basically saying is you can do an awake surgery guided by advanced imaging. You can remove most certainly almost all or practically all of the tumor, but by managing to keep the patient neurologically intact in the process. And I think the future of neuroimaging will be to do less, less invasive techniques on specific and tiny areas of the brain by using advanced imaging. With that, here's another paper that you can see published on epilepsy research. That's basically my postgraduate thesis on neuroimaging, where we measured an area of the brain known as the piriform cortex, and we measured the difference of the sizes of piriform cortex in patients with temporal lobe epilepsy. And we use a artificial intelligence algorithm known as the geodesic information flow algorithm in order to teach the machine how to segment the areas of the brain we want to use. And we found, of course, differences in volume, meaning that with our algorithm, we can basically diagnose a patient with temporal lobe epilepsy accurately based on the volume of the piriform cortex. And we can show that there's a difference in volume between the right and left areas of the brain, specifically when the patient has either right temporal lobe epilepsy or left temporal lobe epilepsy. With this, I will return to the tiny story I told you at the beginning, the dental hygienist. She was a real patient. We published a case report with feasibility assessment and the segmentation protocol I just told you in the British Journal of Neurosurgery. You can see the link here. This patient indeed had multiple seizures. She couldn't function. She was very young, around 30-something years. We basically segmented her piriform cortex, right? She was taking 7 or 8 anti-seizure medications. We segmented her piriform cortex. We created a 3D multimodality map, which basically joined the segmentation I did with the machine algorithm with tractography, specifically of the optic radiations and of the inferior frontal occipital fasciculus and longitudinal fasciculus. We put it on top of the piriform cortex. We showed the surgeon in real time through the microscope what to extract, what to cut, what to leave. He did it, and at the end, this patient that has been seizing all of her life, that she has been taking 7 or 8 anti-seizure medication until that point, after the surgery and until now, she is seizure-free. She has not had a seizure since. Meaning, we can do minimally invasive surgery. We don't have to cut as much as the brain as we thought we needed to cut. And the patient is basically, let's say, cured. I don't want to say cured because in neurology and in medicine, there's no absolutes. But we have shown a positive benefit in this patient. And I think the future of brain imaging is using its potential of high spatial resolution in order to locate tiny areas of the brain that are functional, and we can operate on them without having to sacrifice a lot of other functional areas of the brain, and we will have better results. And brain surgery is not going to be feared, but rather is going to be like going to the dentist and getting your cavities fixed. Here you can see the segmentation of the piriform cortex. Here are the manual ones that I did, and here you can see the ones that the machine did by itself. Here you can see it mapped in 3 dimensions with the geodesic information flow algorithm. This is the result of the machine. What's basically in green and red, you remove. What's in blue and yellow, you do not, because too close to the lenticus striate arteries that basically feed the internal capsule, and you will cause a major infarct. So as you can see, it's a very tiny, tiny area, millimeters, that needs to be mapped out accurately in order to do the surgery. So the computer algorithm managed to do it well. And here you can see the multimodality map joining all of these techniques together. You can see the piriform cortex here in purple and green, and you can see the optic radiation in yellow and the inferior frontooccipital fasciculus in blue, which are important fasciculus for language and for vision that were respected during surgery and were shown in the microscope to the surgeon in order for him or her to operate on the tumor. You can see the case report again there. So to sum up, multimodality imaging basically utilizes all of the techniques I have told you, packs them together, compares the results, which gives a clearer picture. For instance, if you witness a burglary or witness someone stealing something from another person, if you have the testimony of one person, that can be biased. But if you have the testimony of 1,000 witnesses, the average thing that the 1,000 witnesses say is going to be the closest to reality. Therefore, if we want to see a tumor inside of the brain, will it be better to have one view or 1,000 views? We better to have 1,000 views, right? So we can see the tumor by its blood, we can see tumor by its molecules, we can see its tumor by its relationship with important tracts inside the brain, we can see the volume of the tumor, the specific location of the tumor, we can see the diffusion of water inside of that tumor. And once we have the whole picture of the tumor in 3-modality imaging, we can go and say, okay, I know the tumor is here, I know the characteristics are this, I need to operate like this. So we go in, we extract what we have to extract, we respect what we have to respect, therefore decreasing the surgical footprint in the brain and having a patient that will have minimal neurological deficits after the surgery and will be, hopefully, tumor-free. This is, of course, more difficult with the high-grade tumors, but still, it's possible to do it with low-grade gliomas, and it's possible to maintain intact neurological function afterwards. To sum up, here's a paper talking about the multimodality imaging in epilepsy surgery that we published a systematic review in BMC Neurology, if you're interested to read a bit more about the subject. And there's the issue with all of the things I'm telling you, as we show in this table in the article, is that there's no standardization. There's no standardization between hospitals, even worse between countries. Why? Because we used to think that imaging was not going to go to the depths that it has gone now. We can standardize, we can use it to do good care. It's in constant and rapid evolution. We have even more and more diagnostic capabilities and prognostic capabilities that we did before. These type of techniques are not only to see pretty colors, they're to quantify. We can measure volumes, we can measure intensities, we can measure particles per million. Imaging has moved from being qualitative to being quantitative. The Human Connector project is mapping the connections of all of the brain, and we're going to be able to identify specific areas of function. And just as you do now with 23andMe, you take a tiny swab inside of your cheek, you send it, and they tell you, congratulations, you're 5% African-American, I don't know. So you're 1% Irish, congratulations. So the same thing we're going to be able to do is go into scan our brain, and identify the specific functional areas we have in our brain, where are they located? And if we measure patterns, we can see afterwards, I don't know, you say, oh, you have high calling here and low whatever there. Watch out, you may be in high risk of having schizophrenia in the future. Or you have this, and that. You have a high risk of being a recessive trait for Huntington. So I think this biomarker is going to be the future. We're going to be able to transcend from specifically the mental health field into being too subjective, into becoming even more objective, and showing once and for all that mental health is an organic and physiological thing. It's not only something that is subjective or something that is because the patient is not putting in the effort or he doesn't want to know. It's an organic dysfunction, and it should be treated as such. And finally, we need to measure our populations. Our populations are different from the rest of the world, specifically in Ecuador. We live in high altitude. We have different populations. We can measure the volumes of their brains. We can create a standardized map for Latin America, and we can diagnose Alzheimer's disease, for instance, Parkinson's disease, all the neurodegenerative diseases with a normality map based on our population and not depending on European or United States population that sometimes is not comparable to us. That's it. Just wanted to thank my group. Specifically, I wanted to thank Emilia Cueva for inviting me and the chair. Those are my emails from UDLA and from UCL. I'm open to collaboration with both international teachers and international students. Neural Research Group is a group that I founded, has multiple students. One of them is one of your students, Emilia Cueva. And we're trying to break the mold in research in Latin America and show that all of the research that I have shown you here was done by a Latin American group, by Latin American neurons, by Latin American brains. And even though We're in countries that sometimes they say it's difficult to do research. We're being able to do it and publish it in high impact journals. So I think sky's the limit. We Latin Americans have more neurons and have more capacity, and we just need to give it a go. And you're going to see, as I have seen, that Latin American students, as you are very good, are very intelligent, and are just as capable as any other student in the globe. And what's important is that they're more hungry than other students for knowledge, and that makes us go the extra mile. So that's it. If there's any questions, I will be happy to answer them. Thank you once again for the invitation.
So guys,
My name is Jennifer Velasco. I am my first semester, and my question is, what limitations the current brain imaging technologies still face?
I'm sorry, it's a bit difficult. The audio is a bit hard to hear. Can someone repeat the question? It's a bit difficult in the
yeah,
auditory.
she's approaching.
Oh, no, sorry. So, my question is, what limitations the brain imaging technologies still face?
What is the brain imaging technology? What? Sorry.
What are the limitations, basically?
What are the
these
limitations?
technologies still face nowadays?
What are the limitations, or what? Or
Yeah, what limitations does it still have? Saying that
to acquire the technique, or
Yes.
or to further develop.
money wise, like economically?
That
Yeah.
could be.
Okay, but well, let's talk about limitations of the imaging. So in terms of the application of the imaging technique, specifically in resource limited settings, one of the issues is the cost of the machine, right? So in general, you need to think for each Tesla of MRI, you pay around $800,000 to $1 million. So for instance, a 7 Tesla MRI machine will be $7 million, right? So that's a huge limitation. As the technology advances, it's going to be more accessible. That's one. The second limitation is we don't have a lot of technicians that specialize in MRI. MRI needs to be a technique that should be handled by someone with knowledge of medical physics in order to do it well. Third, the costs can be high, depending on the country. I cannot tell you very well of other countries, but for instance, in Ecuador, an MRI, it's around 300 to 500 US dollars, which is expensive, of course, to people that don't have access to it. And in terms of limitations of the technology itself or the diagnostic capabilities of MRI, you cannot use MRI in a patient that has something magnetic. For instance, someone that has a bone plate or something, metal in their mouths, in their bones, or a pacemaker or something like that. You cannot put it inside of the MRI machine because that's a huge magnet is going to rip it out. So you cannot do MRIs in those patients. And but that's pretty much it. That's the only limitation. MRI, as it uses magnetism, it's completely safe for pregnant patients. It's completely safe for patients with cancer. It doesn't emit radiation. It will never give you cancer. It's very friendly in that way. I don't know if that's your question, or if not, please ask it again. And I'm sorry for not
That's my
being.
question. Thank you.
Sure. Okay.
You have another question?
Yeah. Keep them coming. That's enough. Hi.
Yeah, so what is the cost? Wait, where's the mic? Up there. So what is the cost for one of these MRIs? So let's say that we go there and we take one for a patient with a cancer, with a non-malignant tumor. How much would it cost to run all of this?
Okay, how much will it cost, like in reality, or how much will it? I mean, how much will it cost? Let's say you have. Let me rephrase the question. How much will it cost if you go to a private center or a public center and do it, and you just want the results, or how much does it actually cost if you own a hospital and you want to implement it?
The first one.
First one, okay. So if you go to to a private or public place and you want this type of MRI done, it will be like I said before, around $300, $500 US dollars, right?
The whole, the whole analysis, the whole 3D.
Yes, that's a great question. So what happens is you need the same machine. All of the things I showed you, right? All of the things I showed you are literally done in the same machine. Why? Because all of the things I showed you are just programs. It's just software. Okay. So the good thing of brain imaging is that once you invest on the machine, that is like around 3 million, whatever dollars, it's not that you need more machines to do the other things. You just need the software. There's, of course, software that is ridiculously expensive from houses like Siemens and all of this, right? It's a big pharma and all of that thing. But if you know how to do it, because that's someone you need to know how to do it, there's free software. One is created by UCL, my university. There's other free softwares like Free Surfer, for instance, that you can use the data from your machine and basically create the segmentations I showed you, the volumes I showed you. You can measure the blood volume, whatever you want, and do it for free. There's free software, there's open software that can do that. So basically, yes, the cost will be around that for all of the analysis. Of course, depends on where you go and depends on what professional you consult, because this type of know-how, it's very weird to have in Latin America. Not a lot of people do it. And the price may vary, but when I do it or when someone in my hospital does it, is around 350, 500 US dollars.
Okay, thank you.
Sure.
Oh, yes. We have a question from the chat in Zoom.
Yeah.
And it is, hello, my name is Valeria de los Santos. I am in my 4th semester, and I would like to ask, how can you save a part of the brain that is agonizing?
How can you tell apart? How can you distinguish
How
the
can
part
you
of
save it?
How can you save it? Okay. How can you save it? So when we're talking about stroke, what happens is stroke is usually due to an artery in the brain that is clogged, right? It's blocked. Okay. So when you have this blockage in the artery, right? That artery feeds an area of the brain, the core that already died, but it also feeds an area around the brain that is not being completely irrigated or well irrigated, but by other collaterals. How do you save it? You insert a tiny catheter, right? It's like, imagine like a plastic tube inside of an artery, either the radial artery here beneath your thumb, or the femoral artery, which is in your groin. You insert that tube, right? You start putting inside a wire inside of the arteries. You basically travel from that artery, you go through the aorta in the abdomen, you go through the aorta in the thorax, you go into the aortic arch. From the aortic arch, you take the common carotid artery, you keep going up from the common carotid artery into your neck, you take the internal carotid artery, which will go inside of your skull, and from the internal carotid artery, you can either go to the middle cerebral artery, the anterior cerebral artery, the posterior communicating artery, wherever you need to go with the wire. Once you reach with the wire the area of the blockage, you always see this in real time, how you put the patient inside a room that has a thing that looks like a C, like this, right? Which is a X-ray, right? And you use arteriography. You keep injecting contrast while you see the flow and you see the catheter. You guide the catheter until the blockage, and you pass the catheter through the clot, and on the other side of the catheter, you deploy something that looks like a corkscrew, right? Like what you use to open a wine. You put it in, you basically put the corkscrew inside of the blood clot and just pull, and you remove the blood clot. And then flow is restored to that area of the brain, and the neurons that were dying or drowning can breathe again, and they're safe. But the good thing about stroke, or the thing we need to aim in stroke, is we should be able to treat these patients before 3 or 4.5 hours that the symptoms began. Because when you are able to treat them before that, you even save the area that was going to die. Basically, the patient is completely normal. The brain restores completely itself. But you do that with drugs. There's a specific drug called alteplase, which it's a tissue plasminogen activator that basically dissolves clots. but you can only dissolve clots at the beginning of the infarct, and it should be before the 3 hours. When it's after the 4.5 hours, you need to do this mechanical thrombectomy. That's the name of the technique, mechanical thrombectomy.
Any other questions? We have one, I can repeat it. Yes, speak up. Yeah.
My question is that besides examples that you mentioned, are there any other methodologies that brain imaging can help diagnose? Like
Besides the examples that he mentioned, are there any other mental health
Okay.
issues that can be diagnosed in this way? Did I get it right?
Okay. Yeah, I heard that. I heard that. Yes, there are multiple mental health issues. I just want to point out, I just gave you a few examples of the things we're looking into, right? But they're not used worldwide yet, right? Because we still need to standardize, but some of them can be useful to diagnose. You can basically use these techniques in whatever aspect you can think of. I'm also a teacher in one of the master's degrees in Ecuador in neuropsychology, in clinical neuropsychology, and with my students, we always do as an end of work thesis, either brain MRI in diffusion or spectroscopy or volumetry in diagnosing specific mental illnesses. I will tell you just on the top of my head some of the ones we have found that they're useful. It's useful to differentiate people that are that have psychopathy, that people that are not psychopathy or sociopathy. It's useful to identify between people that are going to have Alzheimer's or people that are just going to have mild cognitive impairment. Is useful to diagnose bipolar disorder, is useful to diagnose schizophrenia, is useful to differentiate late depression from early onset depression, is useful to differentiate resistant treatment depression from that depression that is not going to be treatment resistant, is useful to differentiate specific patterns of symptoms that are going to respond or not to pharmacotherapy in illnesses. What I want you to think about mental illness is that mental illness is a spectrum, right? Let's say depression is a spectrum. When you're depressed, you can either be here or you can be here, right? You can show the same symptoms, but of course, someone that is here is not going to respond to the same treatment as someone that is here. And how are we able to identify these people where they are with imaging? You basically create clusters, right? Groups of people that have specific imaging and symptomatological characteristics, and you can use it to afterwards do it. So my answer will be, it's going to work on every mental health. The issue is we need to standardize it more in order to me being able to tell you, this is how you diagnose. We're still not there. That's the future part of the talk. But what is in the present is that we have seen changes, they are significant, and they show us that this technique will have the potential to do that if we start paying more attention to it and we try to standardize it.
Okay, well, thank you very much. That's all the time we have for questions. We need to move on to the next talk. But once again, let's give a final round of applause.
Great, thank you guys.
Thank you.
Actually, our first review was office. So we used to go to events where they should have a lot of.
Yes. But if not, you can. Hola, doctor, ¿se puede intentar compartir?